So like Erin said, this presentation is intended to provide both a high-level overview of the substantially all predominant test and give a detailed example of how the test works. This is not intended to teach you how to apply the test yourself. As you'll see, detailed projected claims data available only to the health plan is required to do this test. So our primary objective is to allow you to see the test in action and demonstrate that in application, the test is not always going to guarantee the outcome that you might expect. The presentation is going to take a little more than 15 minutes, but we think that questions you have early on may be answered in later slides. So I'm going to ask that you either put your questions into chat or hold your questions until the end of the presentation and just make a note of the slide number if there's one you want us to go back to. Dr. Hennigan will be monitoring the chat during the presentation, and if there are any questions remaining when we come to the end, we'll circle back to them then. Some of the misunderstandings about what MHPAC does and does not require come back to this test. There's a disconnect between what the test requires and what it's perceived to require. In particular, we sometimes hear that quote, a health plan can't require a consumer to pay more for mental health services, but that is not really what the test does. This presentation will identify the parts of a health plan to which the test applies and what the test does and doesn't require. And then last, we'll look at an example applying the test to a fictional health plan. So what does the substantially all predominant test cover? Or in other words, to what aspects of a health plan's benefits does the test apply? This test compares the financial requirements and quantitative treatment limits, or QTLs, that apply to MHSUD benefits within a classification to the financial requirements and QTLs that apply to med-surg benefits within the same classification. Let's first take a brief look at the vocabulary here. Financial requirements are deductibles, co-payments, co-insurance, and MOOPs, or out-of-pocket maximums. QTLs are numerical limits on coverage, such as day or visit limits. And continuing with vocabulary, what are classifications? Well, MHPAC provides 6 different classifications. Inpatient, in and out of network, outpatient, in and out of network, emergency care, and prescription drug. Subdivision of some of these classifications is permitted when evaluating compliance using the substantially all predominant test. Most notably for purposes of the test, MHPAC allows plans to subdivide outpatient services into office visits and all other outpatient items and services. This means that when applying MHPAC, plans are permitted to test these subdivisions separately. And we'll see an illustration of this when we step through our detailed example at the end of the presentation. So first, what does a substantially all predominant test require and what does it not require? And we'll start with what it does require. Let's look at this statement of the test. The financial requirements and QTLs that apply to MHSUD benefits within a classification must be no more restrictive than the predominant financial requirements or QTLs that apply to substantially all med-surg benefits within that same classification. As defined by MHPAC, predominant means more than 1/2 based on expected annual plan payments, and substantially all means at least 2/3 based on expected annual plan payments. We'll break the test down to look at the 2 parts in more detail in a few slides. But now that we've seen what it does require, let's look at what it doesn't require. This slide brings us back to one of the common misunderstandings that we hear about MHPAC, the notion that a health plan can't require a consumer to pay more for mental health services. Does the test prevent plans from requiring a greater copay or coinsurance for any MHSUD benefit than for any med-surg benefits? No, it doesn't. The test is used to determine the maximum MHSUD cost share, which is the maximum copay or coinsurance that an insurer may apply to MHSUD benefits. But the cost share for some med-surg benefits may still be lower than the maximum MHSUD cost share that is established by this test. And we're going to be illustrating this with our example at the end of the presentation. Now let's take a closer look at the test itself. Here again, we have a statement of the test, and I'm going to read it at you one more time, and this is the last time, I promise. The financial requirements and QTLs that apply to MHSUD benefits within a classification must be no more restrictive than the predominant financial requirements or QTLs that apply to substantially all med-surg benefits within that same classification. It can be a lot easier to understand by looking at the two parts of the test one at a time. Before we look at the application of the two parts, let's just take a step back a moment to examine their functions. Functionally, step one determines if a financial requirement or QTL can even be applied to MHSUD benefits within a classification. If we get past step one to step two, that is where we determine how much coinsurance, copay, etc. can be applied to MHSUD benefits within a classification. And let me just repeat that. So first we determine if a financial requirement or QTL can even be applied to MHSUD. And if it can, then we determine what level can be applied to MHSUD. So now that we know the function that each step performs, let's look at the technical requirements of each step. Step one is the substantially all portion of the test. Determine if the financial requirement or QTL applies to substantially all med-surg benefits in the classification. Recalling the definition of substantially all, this means that we ask if a particular financial requirement or QTL applies to at least 2/3 of the med-surg benefits in that classification. If we find that some requirement does apply to at least 2/3 of the med-surg benefits, we move on to step two. But if not, then that particular financial requirement or QTL cannot apply to MHSUD benefits in that classification. And you'll see an illustration of this in our example in a little while. If we do make it to step two, it's time to identify the predominant level of financial requirement or QTL. Recalling the definition, this means we are determining the level of financial requirement or QTL that applies to more than half of the med-surg benefits that are subject to the financial requirement or QTL. The financial requirement or QTL that applies to MHSUD benefits in the same classification cannot be more restrictive than this predominant level. Now, if the details of the test are still a little fuzzy, our example scenario applying the test may help. And we're going to jump right into that example of the test. We've created a fictional list of covered benefits and projected claims percentages to illustrate the application of the test in one classification. In this example, we're testing financial requirements, so I'm going to start to read past mention of QTLs, but you know that it also applies to QTLs. We start with step one, determining whether the financial requirements apply to at least 2/3 of the med-surg benefits in a classification. First, our fictional health plan determines which classification they are testing. In this case, we're going to test outpatient in-network services. And to illustrate a subclassification, we are testing the all other items and services category, which is everything except for office visits. Next, the plan identifies the benefits in the outpatient all other classification and the type of financial requirement that applies to each benefit. You can see our list of benefits here: lab, x-ray, outpatient preventative, etc. For most of them, the deductible applies, then the member pays coinsurance. But for outpatient preventative services, the plan pays 100%, and for other facility charges, the member pays a copay. Next, the plan projects the percentage of expected plan costs for each benefit. You can see that in this column that's circled in red. In this example, the plan expects for 10.2% of its total costs in this classification to be paid toward labs. And you can see the expected plan costs for the other outpatient all other benefits listed in this green column. Then the plan identifies the level of financial requirement that applies to each benefit. This appears in the orange columns, also circled in red. Here we see that while the deductible applies to all of these benefits that require coinsurance, the level of coinsurance varies by benefit. Note the percentages at the bottom of each financial requirement column. This displays the total percentage of expected plan costs for benefits for which the financial requirement applies. More on that in the next 2 slides. Let's look at copay first. We see that, measured by expected plan costs, only 8% of med-surg benefits in this classification utilize a copay. 8% is less than 2/3, so the plan may not apply a copay to MHSUD benefits in this classification. Next, let's look at coinsurance and deductible. Measured by expected plan costs, the deductible and coinsurance apply to 90.4% of med-surg benefits in this classification. This is more than 2/3, so the plan is allowed to apply deductible and coinsurance to MHSUD benefits in this classification, and we get to move on to step 2. But before we move on, let's look back at what we just accomplished in step 1. Remember that the function of step 1 is to determine if a financial requirement or QTL can be applied to MHSUD benefits within the classification. In our example, the plan determined that the deductible and coinsurance applied to more than 2/3 of med-surg benefits, but copays applied to less than 2/3 of med-surg benefits. So the deductible and coinsurance can apply to MHSUD, but copays may not. Now recall the function of step 2. Step 2 determines the level of financial requirement that can be applied to MHSUD benefits within the classification. Well, deductible does not vary by benefit, so there's not going to be a predominant level of deductible. But the plan must now determine what level of coinsurance may apply to MHSUD benefits in the classification. We're delving into step 2 now, but I just want you to note the underlined language here. We are determining the level of financial requirement that applies to more than half of the med-surg benefits that are subject to the financial requirement or QTL. That is slightly different than the metric we were using before. So the plan has to recalculate the percentages of expected plan costs only for benefits for which coinsurance applies. You can see that in the second green column circled in red, the numbers have changed slightly. The benefits for which coinsurance and the deductible did not apply no longer go into the total percentage of plan costs. You can see that outpatient preventative and other facility have been stricken from the total because they were either paid at 100% or had a copay, not coinsurance. As a result, all of the other numbers increase slightly because they still need to total up to 100%. These are the percentages that the plan will work with as it continues step 2 of the test. You can see here that the plan is aggregating the expected plan costs for benefits that have the same coinsurance level. For example, lab and x-ray both require 20% coinsurance, and together those benefits account for 38.5% of expected plan costs for benefits where coinsurance applies. The plan also has aggregated the expected costs at the other coinsurance levels. But you may note that no one coinsurance level makes up more than half of the expected plan costs. If no single level applies to more than half of the med-surg benefits that are subject to this financial requirement, the plan combines levels until the combination applies to more than half of the med-surg benefits. And we'll see them do that on the following slide. Beginning with the most restrictive or least generous level of cost sharing, the plan aggregates levels until it exceeds 50% of projected plan costs. We see that combining the 50% coinsurance level and the 30% coinsurance level benefits is only about 24% of projected plan costs. But adding the 25% level coinsurance benefits to those brings us over 50% projected plan costs. The plan now has a combination of coinsurance levels that exceeds 50% of projected plan costs. But which of the coinsurance levels within the combination is considered the predominant level? The least restrictive or most generous level of cost sharing within the combination is considered the predominant level. In this example, that is the 25% coinsurance level. This fictional health plan may require 25% coinsurance for MHSUD benefits in the outpatient all other services classification. This is the maximum MHSUD benefit cost share in this classification. But note that the X-ray and labs med-surg benefits in this classification only require 20% coinsurance. Because of the results of this test, the plan could require 25% coinsurance for MHSUD benefits, even though some med-surg benefits in this classification only require 20% coinsurance. So let's summarize what we saw in this example. In our example, the plan determined that the deductible and coinsurance applied to more than 2/3 of med-surg benefits, but copays applied to less than 2/3 of med-surg benefits. So the deductible and coinsurance can apply to MHSUD, but copays may not. The plan then determined that it could apply up to a 25% coinsurance to MHSUD benefits because that was the amount that applied to more than half of the med-surg benefits in this classification. And we also saw that there were some med-surg benefits that might still have a lower coinsurance than MHSUD benefits in this classification. That brings us to the end of our example and the presentation.